So hello and welcome to this second session on the European Resuscitation Council guidelines. My name is Gavin Perkins and I'm the Director of Guidelines and ILCOR for the European Resuscitation Council. This is an exciting session and we've got some of the world-leading experts on ethics, paediatric resuscitation, neonatal resuscitation, first aid and education that are going to share with you brief summaries of their draft guidelines, which have been submitted for your comment and your feedback prior to us finalising them early next year. Just as a reminder to people that the full versions of the presentations that you're going to see are available on the ERC virtual website, and you're able to look through those and have a look outside of this session. As a reminder, you can access the draft guidelines from the European Resuscitation Council website. The URL for that is www.erc.edu. And if you move down to the bottom of the screen and click on the European Resuscitation Guidelines for public comment, that will then take you to a screen where you're able to select and download the various guidelines. Looking at the neonatal one, we've divided the guidelines into two main sections. We have the concise guidelines for clinical practice, which are an executive summary of the actions that should be taken in specific situations. And then we have a longer detailed session, the evidence informing the guidelines, that explains the rationale for the various recommendations that we've presented to you for public comment. In terms of submitting your comments, these can be done from the guideline website, which will then take you on to a survey where you have the opportunity to enter your comments on the guidelines. And we'd encourage you to provide feedback as well as asking questions in this session to share that feedback with us. So without further ado, I'm going to start this session off. I'm going to invite my co-chair, Hilde Gunnar, to say hello initially before I introduce the first speaker. Hilde Gunnar.
Yes, thank you very much, Gavin, for that. Hello to everyone. I'm Hilde Gunnar Svavarsdóttir. I come from Iceland, and I'm also the secretary of the ERC board. I'm looking forward to being with you here today. Thank you, Gavin.
Great. So without further ado, I go to our first speaker, Patrick van der Voorde, who's the lead of the paediatric writing group. Patrick, very much look forward to hearing your insights into paediatric resuscitation. Patrick, you're on mute.
This is better. Okay. What I was saying is that I've got a few minutes to talk to you about the pediatric upcoming 2021 guidelines, actually, which is an endeavor because pediatric guidelines start pre-arrests, covered all of basic and advanced life support up to the post-arrest setting. These guidelines are, and that's also a problem of obviously with pediatrics, there is not much evidence there. It's often very low certainty evidence, but there is a need for guidelines. These guidelines needs to have sufficient rigor and applicability. And what we also want with these guidelines is stakeholder involvement. That's why we are presenting them now to you in a draft version, as Gavin already explained. These guidelines are based on science, but equally we took very much into account whether or not it has educational efficiency and it's implementable. Only looking at what's new, we define children as anybody between the age of 0 to 18 years, knowing that if somebody looks like an adult, you can use the adult guidelines, but also looking at the very early age where actually neonatal guidelines only apply to transition at birth. We very often use the word competent provider in our guidelines, defining that person that has sufficient knowledge, skills, and attitudes to perform or lead the procedure to a certain level demanded by society. It's difficult to define sufficient, but it's an important concept to take into account for all the things we do. They should be done by competent providers. If you look at the pre-arrest, we adjusted the normal values for age because our previous values were no longer supported, I think, by literature. We very clearly discussed that oxygen, as in adults, is a drug and should be tailored to a certain goal, knowing that in case you are unable to yet tailor this FiO2 because you do not have accurate measurement, then in cases of respiratory and circulatory failure, we still advocate high FiO2 at start. We also emphasize the importance of back mask ventilation as a standard first line of treatment. Circulatory failure, although it's a term used quite regularly as such, it's not one disease and treatment should be tailored to the individual. A big change, although it's not necessarily the fact that you would not give up to 40 to 60 mils to an individual patient, or fluid bolus unit in a way has diminished to 10 mils per kilo, giving more emphasis on the frequency of reassessment, meaning that after every 10 mils per kilo, one should reassess the effect and see whether extra boluses are needed. And we also emphasize the importance of early vasoactive drug use. For basic life support, there's always been those with a duty to respond and other terms used. We redefined actually to the following, meaning categories. You either are untrained, you are BLS trained, you are PBLS trained, or you're advanced trained. And there's no other categories. And this will depend on, or this will guide them what you should be able to do during BLS and ALS. Focusing on safety, obviously in COVID times, focusing on time, and the important change there is that a single rescuer will also call immediately after having done the 5 rescue breaths, but before the compressions, knowing that, for instance, in the adults, as in children, we now have mobile phones with speaker functions that would facilitate this process. We also would not stop after the rescue breaths to evaluate circulation. If somebody received rescue breaths is still unresponsive, not breathing, that we immediately proceed with chest compressions. And as for skills, the emphasis is on back mask ventilation, and for infant chest compressions, even for the single rescuer, we would advocate 2-thumb encircling technique. There's a small risk of insufficient recoil, so this is something that we need to pick up in training, but the impact on compression depth and fatigue is clearly in favor of 2-thumb encircling technique. Finally, for ALS, it's still a single shock of 4 joules per kilo, except for those specific settings where as in adults, there is a witnessed arrest of a shockable rhythm and the defib is immediately available. What always has been a difficulty is in case there is already an endotracheal tube in place and you can do positive pressure ventilation, then this ventilation can be asynchronic with continuous compressions, but the rate of ventilation then will depend on age. It will be 10 as in adults for up 12s, but will be faster as the child is smaller, up to 25 per minute for infants. And this is a change compared to the previous guidelines. And that was it. So actually I can end with this slide. Thank you very much. And I'll stop my sharing.
So thank you very much, Patrick, for a great talk there. So I'd like to remind the audience that the question function, you can pose questions to the speakers through the ERC virtual website, through the Slido function. If you put questions into the chat function there, myself and my co-chair Hilde Gunnar will put those questions to the writing group members. So Patrick, to start off with that, there have been 2 or 3 questions that have come in. The first is what are the plans for the publication of the paediatric guidelines in terms of when do you anticipate those will be posted on the ERC website?
Yeah, because of course we need to cover from pre-arrest to post-arrest and BLS and ALS and special circumstances in between. The chapter was very long in terms of editing. We are still tweaking on the first part, so it becomes in line with all the other sessions, but I expect all the other chapters, but I expect it to have them in paper on the website by the end of next week after the Congress. Obviously, this video and the longer video of the presentation is already available underneath, and we're already happy to take comments, but I expect the latest in the beginning of November to also be online with the full text in draft, meaning that this is something that, depending on your comments, can still need adjustment. It is not a finished product, but obviously near finishment, like everybody else.
Okay, thank you, Patrick. So, some general comments that have come through on the chat function that I think probably apply to everybody, and I think Charles has responded to this to identify the relevant section in the neonatal guidelines, but some feedback we've had is the usefulness of a summary of changes section. So I think, you know, that's already some useful feedback to have received from Paul Slater, and thank you, Charles, for pointing out where that is in the neonatal guidelines. I'd encourage people that in addition to providing this feedback, please do go to the ERC website and formally log any specific feedback like that, because it's only when we get that information collated together in one place that we can really make sure that we're responding appropriately to everybody's feedback. A specific question that's come through, Patrick, relating to paediatrics is the role of automated external defibrillation in children and what guidance you provide in that setting.
Mm-hmm. It's always been a bit of a difficulty because there's obviously a balance between the fact that the majority of our arrests are hypoxic ischemic in nature, but even there we know that there might be a secondary shockable rhythm, and still an AED might be relevant because in these cases that might still make a difference. So the guideline as of now is that if you're a single rescuer, obviously will not go and collect an AED unless it's like 10 centimeters away from you. But if you're two rescuers, even in BLS, the second rescuer will collect an AED and will apply as available.
Okay, thank you. Brian Finley is asking if the guidelines will make clear that for the lay rescuer, the ratio is still 30 to 2. So I guess, firstly, can you confirm that that is indeed the case, and how that will be communicated to people?
Well, like I said, we redefined, because lay and duty to respond were terms that are very difficult. So if you are PBLS trained, you should be using 15 to 2. If you're BLS trained, I think you would be using 30 to 2. And if you're untrained, I think for the dispatcher assisting, probably 30 to 2 is also the easier way to move forward.
Okay, that's terrific. So there's a lot more questions there, but in the interests of time, I'm going to thank you, Patrick, for that excellent presentation. Patrick may get the opportunity to reply in the Slido function to people, and if we have some more time at the end, we'll come back and pose some questions to Patrick at that point. I'm going to hand over now to my co-chair, Hilde Gunnar, who's going to introduce the next speaker.
Thank you, Gavin. Yeah, it's my pleasure to introduce the next speaker. That's Charles Rohr, who comes from Oxford, England, and works in the newborn services there. He is also the science chair of the ERC NLS Science and Education Committee, and he is going to walk us through the latest information, or what will be included in the neonatal guidelines. You can go on, Charles.
Thank you very much, everybody. Thanks for asking me to give a little overview. As Gavin said earlier, we have posted the draft guidelines on the ERC website, and today I'm just going to give you a teaser of what's happening, what you will find in these guidelines. And thankfully, the guidelines are structured so that you can see the changes right at the top. For the sake of this little introduction into what's happening, let me just remind you that we have a very active process of now dynamically doing an evidence review, and whilst we will do repeated and probably 5-yearly guidelines updates, we will definitely communicate the latest of the resuscitation science with the community through the ERC website, through the related journals, and through pertinent communication if necessary. So please be mindful that at this time of day, we have a draft which you find on the internet, and we're very, very much looking forward to you leaving your comments to what's been written. Hugely admiring the leadership by John Mader, who led a team of 11 now guideline co-authors. We split the work. We had a good year and a half of working together to come to what you will find on the website now. But please be mindful that until the ERC guidelines and the proper guidances for the resuscitation councils have been issued, probably early next year, we remain on what we have based on the 2015 guide. We spent some time thinking as neonatologists on what's the ideal oxygen concentration, and there's more detail in the full slide, which I hope you will all enjoy offline, but the question about the initial oxygen concentration from birth is still quite heatedly debated, despite a lot of research in this area. The ILCOR group on neonatal guidelines took this on by commissioning systematic reviews. 2 reviews in total addressing the optimal starting oxygen concentration for preterm babies and for term babies have been published after years of scrutinous work over the earlier last year. Michelle Walsh led a group of investigators looking at preterm infants, and there's no definite answer at this moment, and that's, it is reflective of the evidence out there. We now know that for babies born less than 32 weeks of gestation will require some form of oxygen. We know that 100% oxygen in the past has been looked critically upon with regards to persistent oxygen stress and possible ongoing injury. The basis of the bulk of the evidence, therefore, never really looked at many studies. Only one actually looked at high oxygen concentration, 100%. All the other studies looked at less than 100% oxygen concentration and compared it with room air, as we would suggest in the term-born infants with compromise, or slightly higher concentrations. And it is therefore that we can't really suss out the optimal oxygen concentration, ideally, of course, stratified by gestational age, maybe even disease state of the baby. But we appreciate that the optimal starting concentration is somewhere between air and maybe 30% on the whole. Maybe other babies need more. Some babies definitely get very well by with room air. We can this far only assess that probably start with somewhere more between air and 30% for preterm infants less than 32 weeks. For the term-born infant, although a couple of new studies were found, and in a very systematic Cochrane review-like meta-analysis, we went back to the original investigators and asked, what's the metadata that we can't find in your publications? What's the on follow-up data that you may not have published? And we got a lot of additional information to even the latest systematic review published in 2018 by Saugstad et al. And we can say with great certainty now that there's a near to 30% relative reduction in short-term mortality if you start with room air compared to 100% oxygen. And that is for all babies born at or near term. We defined it as babies born at 35 weeks or greater. We spend currently a lot of time still debating on how to best give breathing support at birth. It is no longer a one-size-fits-all. A compromised baby comes out and you should put a mask on the face and start giving PEEP or CPAP. There's some appreciation that a subgroup of babies will actually go and develop a dive reflex and then stop breathing altogether. So we will need to learn much more about who to help appropriately in which way and with what device. Now, for the current guidelines, based on the best available evidence, we appreciate that every lung is different, and but the physics of lung aeration applies to all lungs the same. So whilst if you look at this slide, which I was given by my friend and mentor Stuart Hooper, a physiologist from Monash in Australia, if you look at a terminal airway here illustrated as a bronchioli and an alveolus, fluid-filled lung at birth needs to be aerated. And to aerate the terminal airways, the pressure difference between P1 and P2 needs to be overcome. The resistance in the tube equals the viscosity of the gas or fluid times the length of the tube over the radius to the power of 4. Interestingly, term-born infants can overcome this pressure difference very easily by a few good old inspiration breaths. However, because the viscosity of a fluid-filled lung is about 25 times higher than the viscosity of an air-filled lung, particularly the smaller ones might require more pressure. And we address this fact based on current evidence to go a little bit beyond what we said in 2015, that we suggested 20 to 25 centimeters for preterm infants and 30 centimeters for term-born infants, to now being more permissive, and we set the margin, the mean at 25 centimeters of water air pressure for the inflation of preterm infant lungs. More of this also in the full presentation. A lot of debate in the neonatal field has been gone into whether the first couple of breaths should be supported with a long inspiration time. I'm talking about an inspiration time of 5 to 15 seconds. Great animal data, really, really convincing, but very worrisome clinical evidence led us to actually abandon this. There would be many issues to suss out, like for instance, have the studies investigating those sustained inflation looked at the right kind of pressure? Have they looked at the best possible patient group? Who are they most fitted to? We don't know this. What we know is the smaller the baby, the worse they seem to fare with sustained inflation, and therefore we discourage doing this at this time. How can we improve on this? Because animal data is very convincing. Maybe future clinical studies should look at a stepwise increment of the inflation pressure or repeated sustained inflations. We need to learn more about whether monitoring helps provide better support at birth, and whether we need online feedback, maybe even feedback on the acute state of lung inflation whilst we're doing stuff. For this moment in time, we had no reason to change the 5 inflation breaths of 2 to 3 seconds, because there's no evidence of harm, there's no evidence of inferiority. Therefore, we suppose to keep that afloat. And just as the last teaser and the biggest recommendation, well, one of the most significant recommendation as perceived in 2015 was that we, in the ERC guidelines, discouraged from routine oropharyngeal and tracheal suctioning in the face of amniotic stained fluid. we have had a couple of publications from the US who investigated a post-change impact on neonatal services caring for babies born through meconium-stained amniotic fluid, with quite some different diverging results of these retrospective reviews. We have one prospective study from the UK that looks into the impact of the change in this policy, and these authors summarize that, and it's been a great relief, as you can imagine, that withholding the routine of oral or tracheal suctioning did not result in more meconium aspiration syndrome, but the adoption of a more permissive ventilate first before you even attend to suctioning in the face of meconium-stained amniotic fluid resulted in fewer babies being admitted to the neonatal intensive care unit to treat for meconium aspiration. A lot of talk has gone into how to provide initial ventilation support. The good old safe inflating bag is present everywhere. The flow inflating bag, much loved by our anesthetist friends, is very rarely used in neonatal care settings. And the T-piece, continuous flow, pressure controlled, CPAP providing devices are very popular. The verdict on whether a self-inflating bag or a T-piece resuscitator is beneficial for supporting initial resuscitation of preterm, particularly preterm infants, is still out. There are national cohort studies addressing these questions, from particularly in South America. And a couple of investigators have done a scoping review, one of them was me, and we concluded that there's sufficient new evidence coming out of this systematic, well, a small scoping review to warrant full systematic review, and that is still work in progress. For now, we know that another effective way to provide
30 seconds to go, Charles. Thank you.
I'm going, okay. So let me just summarize that we've got an adopted continuous evidence review process. Please leave us our feedback to your guideline, to the draft guidelines, look at the changes, and we look forward to engaging with you continuously.
Thank you very much for that, Charles. It's certainly an exciting topic, and I'm sure the people working with neonates will be very excited to look up on the guideline, the draft guideline, and I encourage them to have a look and leave some comments on the website so that you can work with that in the late future. Because of time, I think we just have to go on, and I just remind you to leave questions on Slido, or as I say, leave comments on the public comments, and I hand over to my co-chair Gavin in order to present the next speaker.
Thank you very much, Hildegard, and thank you, Charles. So it's my pleasure to introduce our next speaker, David Zeidman, who's going to share the new information on first aid. Thank you, David.
Thank you. I'm just trying to share my screen at the moment. So if we can get that up. Have you got that? Oh, I've cut myself off completely. Sorry, Gavin.
That's okay. You're still with us, David, but we can't see your slides at the moment.
Yeah. Should be there.
Perfect.
Is that all right?
Great.
Okay. Sorry, I will go to full screen as well. So thank you very much. Thank you, Gavin, for your patience with me as well. I should be used to this by now. Greetings from outer space. I thought I'd come from a little bit further away than just London, basically. I'm hoping to get away from COVID by being this far out. And in view of time, and I'm very conscious that things are moving on, I'm going to move fairly rapidly through the guidelines 2020 first aid. First aid was first introduced to the European resuscitation back in 2015. And it was great fun actually taking these and looking at what was actually relevant to resuscitation and therefore what would be relevant to the European Resuscitation Council. Some of you may say that some of the topics we picked may be slightly, well, may not be at all relevant to resuscitation. We think that there may be something in the background which some of you may not have thought about, basically. So I had a expert working group. They really were. They came from all over Europe, and we've even got my co-chair or my chairman from ILCOR, Nisi Singletree, to come and help as well. So they saw the writing on the wall and actually helped by doing a tremendous amount of work to put these guidelines in place. The guidelines themselves, there were a total of 19 reviews done by ILCOR on the consensus of science, the consensus of science and treatment recommendations for 2020. And as many of you have seen, those have just been published in the last 24 hours. And you can go and look at all the background and the tremendous amount of work that's gone into there. I think it's something in the region of over 400 references. The 19 reviews comprised of 9 systematic reviews, all of which have been published now. The 8 scoping reviews, which are now included in the new COSTAR document for ILCOR, as are the 2 evidence updates that support the evidence behind first aid. And I'll say right at the beginning that there is very little evidence, and much of it is extrapolated from hospital work, from the work of healthcare professionals. But as first aid can be delivered by anybody, we felt that it was worth trying to extrapolate and trying to see where we went. So this is the first slide from my pre-prepared lecture. I'm not going to go through this in detail again. I hope you've enjoyed the lecture I've given you, the 10-minute lecture that you should have seen already. I'll just run through the topics that I selected because some of these were new and some of the ideas behind them were new as well. So recovery position was selected. I selected because, and it was selected again because we responded to the response to the 2015 guideline, ERC guideline, about turning people into the recovery position who actually needed resuscitation. And you will see now that that has had a full systematic review done on it, basically, and we are now talking in terms of only turning somebody who has got abnormal or hasn't got normal breathing. And this has gone into in some detail within the actual guideline itself. Recognition of stroke, very quickly, we recommend that people do use a stroke scale. And for most people, I think they're still using FAST, because this is a relatively simple first aid emergency scale. You don't have to remember a very complicated or complex algorithm. You'll see there's other things here like early aspirin, anaphylaxis, which is actually dealt with under special circumstances and even in basic life support. This was about second dose of adrenaline or epinephrine. And one of the big highlights was the management of heat stroke cooling, which we'll go into. I didn't go into in my talk, but we will go into this in a great deal of detail when we have our talk tomorrow evening in first aid. Nisi is going to go through this in quite a lot of detail because it's quite an important and quite an interesting subject. But basically, it's plunging people into cold water, tends to cool people who are over 40 degrees, and this could be a life-saving measure. It is a pre-arrest measure. But more questions about that, please, if necessary. Going to trauma first aid, moving through these fairly quickly. Control of life-threatening bleeding. We looked at, again, we did a mega PICO where we actually looked at pressure dressings, hemostatic devices, and tourniquets. We found, to keep it very simple, you press on a bleeding wound. If you can use a pressure dressing or a hemostatic dressing, that's an added advantage. Basically, we found no indication for any hemostatic devices at all. And we recommend that if tourniquets could be applied, for example, on a peripheral limb, they should be applied. But we have made the points in the guidelines about once you've got a tourniquet on, it should not be removed. It should stay there until a healthcare professional can remove it, despite a lot of first aid advice saying that you should remove the tourniquet every 10 minutes to allow the limb to perfuse. That is not acceptable practice. open chest wounds, but cervical spine motion restriction and stabilization. A lot of chat last time from 2015. Again, we've tried to look at this in more detail. We still do not recommend the use of collars, and we recommend the use of either holding the head directly by a first aider, or if necessary, and the person, the victim is conscious, they should be able to hold the head themselves in a comfortable position, because any injury will probably cause them pain. Thermal burns, we looked at thermal burn dressings and didn't actually find anything to particularly be recommended. We looked at cooling very quickly. We have extended the cooling time to 20 minutes now from the original 10 to 15. That fits with international guidelines. But the thermal burn dressing, nothing particular. If you like to smear honey on your burns, that seems to actually do some good and help people. But most people, I think, should follow the advice, the use of cling film or cling wrap, basically wrap loosely around a thermal burn, basically, actually does protect quite well. And finally, compression wrap for closed extremity joint injuries. This was a very peculiar, it shows you how things can go wrong when you're actually looking at these PICO questions. This was looking at compression wrap applied alone. It was not applied to, or wasn't used as a question to look at as part of a rest, the RICE sequence, the rest, ice, compression, and elevation. But as on its own, compression wrap has not been indicated, or did not have any indications to be used on its own. However, probably being used as part of a RICE, rest, ice, compression, and elevation, it probably may have some indication, but that will have to be looked at again. So just a rapid run through of the first aid emergencies, both medical and traumatic. In view of time, Gavin, I'm going to say thank you very much. And if you've got questions, then please do ask them. And I refer you to my lecture and also to the talk on Saturday, on Friday rather. And finally, of course, there are the draft guidelines on the ERC website for you to review. This, unfortunately, is an older version that has been put on there, and we will please ignore the grammatical errors. Those will be corrected as we go along. But thank you very much. Over to you, Gavin.
David, thank you very much for an excellent talk. Really clear and pulling out the key messages. Now, you'll have to remind me. The first aid guidelines include the recovery position. Is that correct?
Yes. So yeah. The first aid guidelines are currently including the recovery position. But we have been discussing, we've just literally opened discussions with BLS and EIT, because we believe that part of the problem with recovery position is not the actual position itself, but the ingrained belief that anybody who is unresponsive should be turned on their side automatically. So it may be a BLS concept, it may be an EIT, and I know EIT are coming up next, so it may be an education thing we may have to change, but this will be a bigger discussion within ILCOR and ERC.
No, that's great, and I guess just thinking about some of the the feedback, and I guess Tony Hanley may be disappointed, but people have referred to it as the position of death. What's your perspective on that?
I'm sure if Tony was here and if he's on this at all, basically he will have actually written you a red hot reply by now. I can fully understand that, but I really do think so. The recovery position is useful. It's as an anaesthetist and you as an intensivist, for a long time basically that you use recovery position if you can't, if somebody's trying to recover basically and they are breathing normally, this is a safe position for them, stops the airway obstructing. So my comment would be, I would only put somebody into the recovery position if I was actually going to leave them having to go somewhere else to, for example, to go and get help, but they were breathing normally. What I don't want them to do is be lying on their back. And we've all seen the newspaper reports of children and young adults being left lying on their back. They vomit, and when they come back, they're dead. So I think there's quite a bit to still explore, but I think we have to get away from the old-fashioned teaching of resuscitation. The recovery position is the thing to do, the first thing to do when you arrive at somebody who's not responding.
Great. So the key, as you say, is all around the diagnosis and the correct use of the recovery position. That's terrific. I think in the interests of time, we're going to
Thank you, Kevin.
The next speaker. Do stay on in case we have a few minutes at the end. I'm going to hand back to Hildegunn and my co-chair now to introduce the next speaker.
Thank you. Yes, it's my pleasure to introduce the next one, and that's Tino Greif, who is a professor at the Bern University Hospital in Switzerland. He is the Director of Training and Education in the ERC Board, and he's also the chair of the ILCOR Task Force Education, Implementation and Team. And he's going to guide us through the educational part of the new guidelines.
Thanks for giving me the opportunity to talk about this educational chapter, and I try to share now my screen. Okay. And it seems that, yeah, it looks like it worked. So, as Hildegunn said, I'm the Board Director of Training and Education, and I had the pleasure to lead the chapter writing group. And you see all the names here. This is a very vivid group, and we had a lot of discussions. I will very shortly go over this topic because I give a presentation. You can see and read all the listen to all this later. No, it's not changing. It's interesting. Okay. Got it. What we did this time, the educational chapter is totally new. So we thought to give really the background of how are we teaching. And on the other hand, we followed the structure of all the other chapters. So you have an introduction, concise guidelines, and then the evidence informing about these guidelines. This is all based on evidence. This goes back to the task force of ILCOR on education implementation and team, where we had 14 systematic reviews, 4 scoping reviews, and 7 evidence updates, which gave the background to these guidelines. And these are summarized in the Consensus of Science and Treatment recommendation, which were published yesterday. And for those who are interested, large chapter.
So Tino, we've lost your audio, I think. Hildegunn is, can you hear Tino?
No, I cannot hear him. He's just breaking.
So is the chairperson able to mute Tino and remove him from sharing screen? And we'll maybe go to Spiros while we aim to sort out the audio problem.
So thank you very much. I am Spiros Mentzelopoulos, and I come from Athens, Greece. I'm a professor of intensive care medicine. I would like to thank very much the ERC for the honor of inviting me to give this lecture. And I will share now my presentation. So these guidelines have been developed with a contribution of 11 authors. And I assure you this has been quite a bit of work. So our objective was to provide evidence-based recommendation for the ethical and routine practice of resuscitation and end-of-life care of adults and children. And the primary focus was on major ethical practice interventions, such as advanced directives, advanced care planning, and shared decision-making, and also decision-making regarding resuscitation, education, patient outcomes, and research. We also provided core definitions, which are actually in the supplement of our guidelines, but also certain important definitions are in the tables included with a draft that is available at the ERC website for commenting. I'm just stating an example that ACP is a process that enables individuals to define goals and preferences for future medical treatment and care, to thoroughly discuss these goals and preferences with family and healthcare providers, and to record and review these preferences if appropriate. And here are our key recommendations. There is supporting evidence for advanced directives, for advanced care planning, and shared decision-making. There is also supporting evidence in the literature for the use of communication interventions, including education of healthcare professionals. We should use technology to prevent the coronavirus disease 19 from preventing advanced care planning and shared decision-making. And what are our targets in which mainly advanced care planning and shared decision-making seem to help? The consistency of treatment actually administered with patient preferences, the potential reduction in the use of inadvisable life-sustaining treatments, the frequency of preferred dying at home, and perhaps less use of end-of-life ICU or hospital care, of course in concordance with patient preferences. The potential effect in the improvement in quality of life, and also satisfaction, and perhaps a reduction in the time to limitation decisions. Now, our most important recommendation, perhaps, was to use advanced care planning that incorporates shared decision-making. As regards the major interventions at safeguarding autonomy, which was the first section of our guideline. Now, the second section pertains to when to start and when to stop CPR, actually resuscitation decisions. Examples of criteria for CPR decisions are return of spontaneous circulation, whether a shock has been delivered, or whether a cardiac arrest has been witnessed or unwitnessed. We should document reasons for withholding CPR. We should implement clearly predefined criteria for early transport of resuscitated patients. We should mind the rescuers' health safety, especially these times, both in the out-of-hospital and the in-hospital setting. We should not employ categorical or blanket criteria for DNA CPR decisions, meaning that we should not say that there will be a DNA CPR order for everyone aged above 75, for example. We should use transparent criteria for organ donation. We should evaluate bystander CPR in the context of healthcare system resources, and we should promote family presence during resuscitation. And the key recommendation for this second section of our guideline is where to use predefined criteria for withholding or terminating CPR, such as asystole for at least with advanced life support for at least 20 minutes on irreversible cause, or that we should not base decisions on isolated clinical signs or markers of poor prognosis, such as pupil size or lactate or CPR duration or cardiac arrest in the context of a suicide attempt. And these criteria should be predefined when we decide not to continue resuscitation, that is to either withdraw resuscitation or withhold it from the beginning. Now, the third part of our guideline concerned education, communication, and system organization. And the major suggestions from this part were to educate lay persons and persons at risk of cardiac arrest about autonomy and CPR indications and procedures and outcome, and also educate healthcare professionals in DNA CPR discussions, advanced care planning discussions, family presence during resuscitation, and also empathic engagement with family and bystanders. The last section of our guideline pertained to ethics and emergency research, and the main recommendations were to involve patients and public throughout the process of emergency research, and also for observational research to consider a broad deferred consent model with safeguards. In conclusion, we provided simple and clear, in our opinion, recommendations supported by 35 systematic reviews with 11 meta-analyses and more than 250 randomized controlled trials and non-randomized studies. Despite some imprecision of meta-analysis effect estimates, the overall direction of the effects favors advanced care planning, shared decision-making, and termination of resuscitation rules. We also provided 3 narrative reviews for education, patient outcomes, and research. Lastly, we provided consensus definitions of key terms for routine practice and research protocols. I would like to thank you very much for your attention.
So thank you very much, Spiros, for stepping in at short notice and delivering, such an insightful talk. I'm going to ask Tino Grief if he could just unmute so we can just test his microphone before coming back to Spiros with a question. Tino.
Do you hear me?
That's much
Yes.
better, yes. Thank you, Tino. So if you could mute yourself, I'm going to ask Spiros a quick question.
I did not change anything.
Okay, that's good. So Spiros, an incredible piece of work you and the team have done there, 35 systematic reviews in a series of meta-analyses. What would you say is the most important thing that you've learned from that piece of work in relation to resuscitation practice?
Well, I would say that I learned that well-structured interventions aimed at safeguarding autonomy can be very, very helpful in increasing consistency of what patients actually wish to receive as resuscitation.
That's terrific. So,
also, Yes? Mm-hmm.
So, well, thank you, Spiros. That was a huge amount of work, and I really would encourage everybody that's practicing resuscitation to review the ERC draft ethics guidelines, because there's a huge amount of information there that I think we can all learn from. And please do share your comments with the team. So I'm going to hand back to my co-chair, Hilde Gunnar, and we're going to attempt to bring Tino in again. And our apologies for the technical interruption where we lost Tino's audio.
Thank you for that, Gavin, and I'm glad we found Tino again and his voice. So I think we should just hand it back to Tino and hear about the educational part of the guidelines, because as we all know, education is a very important part of the success. So Tino, back to you.
So I have no clue why this didn't work, but now let's go into this. I hope I ended at this point when I started to explain the different chapters of the new guidelines. And first of all, we start with a summary of educational theories behind all this to give a broader picture why we are going to teach this. And then we come up with Now this changes slowly. So the first subchapter is the theory of education behind this. And after that, we have the resuscitation for different groups, which means for lay persons, for healthcare providers, but also for children's. And we have a new subpart on educating the dispatchers. This was not addressed so far. After this, the next part is how are we going to teach the skills of resuscitation? A very important point. And this is followed by technology-enhanced education. This means the e-learning, smartphones, all this stuff coming into CPI education. Simulation takes a huge part in all our courses, and this is addressed in this chapter with all the features, fidelity of the mannequins, but also how to teach simulation, human factors, and non-technical skills. The next part is also very important, the faculty development of our educational staff. So how are we going to train instructors? How are we going to select to keep their competence on a high level over many years, also for the course directors and educators? The next chapter looks a little bit, does this make sense? So do we have evidence that our educational efforts really improve patient outcome? And to say it very shortly, we have the evidence. So our courses improve at the end patient outcome. The last part of this educational chapter looks into gaps of research. So where do we have to look in the future, where to go? And that's all what is in this new chapter. What we tried to do in this new chapter to give you the big overview from the pre-course phase. Why are we doing this? Why do people prepare themselves? Then the on-site course per se, what is going on there, till to the post-course phase where they have to learn. This is the move into lifelong learning, keep your competence on a high level, and the transition to real life, so the application, what you learn on courses or on the internet. This is a new chapter, as I said before. The basis is the evidence from the consensus of science from ILCOR. I ask you to read the chapter, give us comment, provide us improvements you want to see, and select the figures you want to have in this chapter. That's all from my side on education. Sorry for the interruption, but that's the beauty of such a virtual conference.
Thank you very much for that, Tino. That was a much better audio now, as we could, everybody could hear. But at least you got the content of your slides through, which is really, really good. I think we all agree that education is a very important part of bringing the message through. And as we all know, that the effectiveness of survival consists of this three, can say, tiers: the science, education, and implementation, in order to have a good effect on of resuscitation. Tina, could you, because I know there's been a lot of changes and a lot of new ideas about how to bring on education in this field of what we are in this field of resuscitation. Is there something that you would particularly consider as an essential part? I mean, what type of education would you recommend in order for people to at least get the best, can say, learning out of courses? Should they attend courses, go to online courses, or is it a bit of both? Can you tell us something about that?
What we favor nowadays is what we call blended learning. So everything and what suits you. So if somebody likes to learn in front of the computer, they should do it. Some people like to read a book, they should read a book. In one part, resuscitation is also a practical skill. So in some parts, they have to be trained with hands-on, and we want to see that they are doing the stuff correctly. The feedback from outside, from an instructor or a person who knows what they are doing, is so important, because you can do a long time, always the same stuff, but it's wrong. And if nobody corrects you, you are going on with the wrong stuff. So all this together is the principle of our new courses when we try to switch in the ERC to lifelong learning, which means you start with a type of course and then you are going to do an update annually, either on the internet or on the hands-on side, to keep you competent.
Okay.
Thank
you for that,
more or less the question.
Yeah, that's right. I mean, it's mainly that. I mean, there is plenty of options, and people have to really work with what suits them at the best every time. So I encourage you all at least to read through this, because education is also very important for all parts of the different types of resuscitation, being it for pediatrics, adults, or the smaller ones. So I also encourage you, of course, to read the draft comments of this new chapter and leave comments on the ERC website. So I think because of time, we have now finished our session. So I'm sorry, first of all, about the disturbances that we all experienced, but I think we got the message through though, because we could fix that. There are a few questions on Slido, which we are unfortunately not able to answer now, but please, if you can go there and then go back and, as I say, put in comments on the draft guidelines. So I just want to thank you all. I want to thank the speakers, and I want to thank the audience for being with us here on this excellent session about the updates of the different types. And I'm just looking forward to staying with you more. But as for now, it's best for you have to leave this session in order to go on to the next one. And then now, in the meantime, I just encourage you to go around the platform and have a look at the exhibitors, or go into the break room and listen to some music, and keep on enjoying this good Congress. And Gavin, thank you very much for co-chairing. And everybody, thank you very much, and see you later.